Now we're talking about coarctation of aorta in the pediatric cardiology section. Coarctation of aorta. Coarctation of the aorta basically is constriction of the aorta at any point, but most commonly in about 98% of the cases, this narrowing of the aorta is at the region of the ductus arteriosus, which is just distal to the left subclavian artery. So if I draw the arch of aorta right here, see, this is the arch of aorta, this is the brachiocephalic trunk, this is the common carotid artery, and this is the left subclavian. It is distal to this left subclavian artery that the narrowing of the aorta most commonly occurs. So this is narrowed right here, and this is what coarctation is. Narrowing of the aorta, which most commonly occurs distal to the left subclavian artery in the region of the patent in the ductus arteriosus. Coarctation occurs more commonly in boys in a ratio of 2 to 1. It more commonly occurs in boys in a ratio of 2 to 1, and its incidence is increased in patients of Turner syndrome. So females who are suffering from Turner syndrome have a high incidence of coarctation of the aorta. So how do these patients present to you clinically? Well, as you can see, the aorta is narrow right here. So proximal to this narrowing of the aorta, there will be increased pressure of blood proximal to the constriction of the aorta, and distal to this constriction there will be decreased blood pressure. So what will happen is that the blood pressure in the upper extremities will be increased as a result, and the blood pressure in the lower extremities will be decreased as a result of the constriction. And that is what happens in coarctation of the aorta. One of the main features, clinical features of coarctation of the aorta is when you measure the blood pressure in all the 4 limbs, the blood pressure in upper extremities is greater than the lower extremities. Also, on physical examination, when you palpate the radial and the femoral arteries simultaneously, you also find a radiofemoral delay. A radiofemoral delay is experienced when you palpate both the radial and the femoral arteries simultaneously. So this is another feature. Another feature of coarctation of the aorta is that it may be missed in a newborn. When in a neonate, it may be missed if there is a ductus arteriosus, a patent ductus arteriosus, which is connecting the aorta and the pulmonary artery. Then this may be missed, because then the pressure is distributed into the pulmonary artery. So then it can be missed. And another feature that can occur in older children with coarctation of the aorta, when the collateral blood vessels open up, the intercostal blood vessels get engorged, and these intercostal blood vessels can put pressure on the ribs, and they can cause rib notching, which is visible on chest radiographs of these individuals. So these individuals can have rib notching as well. And on auscultation of the chest, on auscultation of the precordium, a systolic, an ejection systolic murmur is also heard in the aortic area. An ejection systolic murmur is also heard. So how is it diagnosed? What are the lab findings? First of all, on the chest x-ray, rib notching can be observed in these individuals. Rib notching can be observed in severe coarctation of the aorta, where there are prominent intercostal vessels. In addition to rib notching, in severe cases of coarctation of the aorta, the patients might have heart failure, and when the patient has heart failure, the chambers of the heart are enlarged due to the increased afterload, increased work against which the heart has to work, the left ventricle has to work. These patients can also present to you with heart failure and enlarged chambers, especially the left ventricle of the heart is enlarged, and they can present to you in heart failure. Also, if an EKG is performed in these patients, EKG in the neonates will show right ventricular enlargement, and as the child grows older, in older children there can be left ventricular hypertrophy seen on an EKG. The definitive diagnosis of coarctation of the aorta can be made by doing an echo. An echocardiography can be done, which will give you the site of narrowing, which will also tell you if there is a patent ductus arteriosus existing, coexisting with it or not. So the definitive diagnosis rests upon an echo. What is the treatment? The treatment of coarctation is surgical correction of the coarctation. In neonates in whom surgical correction may not be possible at that instant, you can give these neonates infusions of prostaglandin E1, which will enable the ductus arteriosus to remain open until the surgery is available. Patient will, with coarctation, develop, as I mentioned, they develop hypertension, and due to that hypertension, they can suffer from coronary artery disease. They can also suffer from heart failure. They can suffer from encephalopathy, intracranial hemorrhages. So these are a few complications of coarctation of the aorta. After coarctation, the next topic that I'm going to be talking about in pediatric cardiology is endocardial cushion defects. Endocardial cushion defects. In endocardial cushion defects, what happens is that there is atrial septal defect. There is atrial septal defect in these neonates, in these infants, associated with a ventricular septal defect, and also associated with valve abnormalities, valve anomalies, atrioventricular valve anomalies. So atrial septal defect associated with the ventricular septal defect, which are contiguous with each other, and also associated with atrioventricular valve abnormalities. Another important association of endocardial cushion defects is that the patients of Down syndrome, trisomy 21, Down syndrome, have an increased incidence of these endocardial cushion defects. Patients with endocardial cushion defects who have large defects have heart failures in infancy, develop heart failure in infancy. And since there are large defects, there is large left to right shunt, and there is massive overload of the pulmonary circulation, and they develop Eisenmenger's physiology or Eisenmenger's syndrome early in the course of their disease. And that is the reason why endocardial cushion defects must be repaired immediately in infancy, so that these patients can have a better chance of survival for a long period of time. When you examine these patients, on examination they have single second heart sound. Without a first heart sound, they have a single second heart sound because they have atrioventricular valvular abnormalities. That is the reason why the heart sound produced by those valves is not present. They only have a single second heart sound, which is produced by the pulmonary and the aortic valves. And in addition to that, they also have a diastolic murmur on examination. When you examine these patients of endocardial cushion defect, they also have a diastolic murmur. What are the laboratory tests that can be done in these patients? The definitive diagnosis can be made by an echo, which will show the defect and the shunt, the extent of the shunt, the size of the shunt. In addition to that, when you perform a chest radiograph, you will also find, in cases of heart failure, the heart will be massively enlarged, all the chambers will be enlarged, and there will be be pulmonary vascular congestion in these patients. And on an EKG, there will be left axis deviation due to left ventricular hypertrophy and other features such as biventricular hypertrophy, right ventricular hypertrophy. All these features due to heart failure may be seen on the EKG. What is the treatment? As I mentioned, these cases must be treated in infancy for them to have a better chance of survival. So they have to be treated, the defect must be repaired in infancy, and the valves also repaired immediately in the infancy, and that is their best chance of survival. Complications depend upon, prognosis and complication depend upon the size of the shunt, and if it is repaired early, then they have better chance of survival. If they are repaired late, and they have a worse chance of survival. So that is all about endocardial Cushing defects. Endocardial Cushing defects. The next congenital anomaly of the heart that I'm going to be talking about is tetralogy of Fallot, or Fallot's tetralogy. As its name suggests, it has got 4 components. The first component is pulmonary stenosis. Pulmonary stenosis. Actually, if this is the pulmonary artery and this is the pulmonary valve, the pulmonary stenosis does not occur at the valvular level usually. It usually does not occur at the valvular level, rather it occurs distal to this valvular level, and this is called as, this portion of the pulmonary artery is called as the infundibulum, where it originates from. So there is infundibular stenosis, or infravalvular stenosis in these cases. So this is the first feature. The second feature is that due to pulmonary stenosis, these patients have right ventricular hypertrophy. Right ventricular hypertrophy. And the third feature is that they have a ventricular septal defect. The blood cannot be pushed into the pulmonary circulation, so it is shunted across into the left ventricle, and since so much blood is being shunted into the left ventricle is also receiving its own blood, there is overriding of the aorta, which is the fourth feature, overriding aorta. So these are the 4 features which constitute Fallot's tetralogy, or tetralogy of Fallot. Now, you must have observed that in Fallot's tetralogy, instead of the left to right shunt, there is a right to left shunt. That is, blood is flowing from the right ventricle through the ventricular septal defect into the left ventricle, rather than the normally what happens is that in ventricular septal defect, blood flows from left ventricle to right ventricle due to the pressure difference. In this case, since there is pulmonary stenosis, the right ventricular hypertrophy, the blood goes from right ventricle to the left ventricle, and there is right to left shunt. And the patients, the infants present clinically, the children present clinically with cyanosis usually. Usually there is cyanosis unless the obstruction is mild, the pulmonary stenosis is mild, and there is sufficient pulmonary blood flow. It is then that the infants or the children might not present with cyanosis, and in that case it is called as acyanotic or pink tetralogy of Fallot. But usually the children present with cyanosis. And neonates usually do not have cyanosis. The reason is that cyanosis will not occur until and unless the shunt becomes a right to left shunt, and that shunt from right to left occurs when there is sufficient right ventricular hypertrophy and sufficient increase in the pressure in the right ventricle, which either equals or exceeds the pressure in the left ventricle, and that is when there is a right to left shunt, and that is when cyanosis occurs. So in neonates, usually the cyanosis does not occur. It occurs in approximately later in life, and it also depends upon the size of the defect and the degree of pulmonary stenosis. So most of these children will present to you with cyanosis. The right ventricular outflow obstruction, that is the infundibular stenosis of the pulmonary artery, is dynamic. This obstruction of the pulmonary artery is dynamic. By dynamic, I mean that on sudden adrenergic stimulation, this infundibulum of the pulmonary artery becomes more narrow and can lead to cyanosis. For example, if an infant cries or feeds, on feeding and crying, there is increased adrenergic stimulation, which leads to narrowing of this infundibulum of the pulmonary artery, further narrowing, which leads to cyanotic spells. Cyanotic spells. That is, there is cyanosis in these infants on crying and on feeding. So these are called as cyanotic spells. They are also called as Fallot's spells. Fallot's spells, which are characteristic feature of Fallot's tetralogy. These cyanotic spells or Fallot spells are sometimes relieved by a squatting position, knee-chest position. So as soon as these children develop these cyanotic spells, they obtain a knee-chest position, which sometimes relieves the cyanosis. And what is the mechanism for that? When the child obtains a knee-chest position or a squatting position, there is increased afterload in the heart, and due to that increased afterload, there is decreased right to left shunt in the heart. There is increased afterload, which leads to decreased right to left shunt, which leads to decreased cyanosis in these patients due to that decreased right to left shunt. So squatting improves the cyanotic spells in some of these cases. In older children, the Fallot's spells or the cyanotic spells are not as frequent as in the neonates. As a child grows old, there is right to left shunt, and they will present to you with features of cyanotic heart disease with digital clubbing, stunted growth, and all those features of heart failure as well. So in addition to that, when you examine these children, you will find an ejection systolic murmur present along the left parasternal bladder, which is of a ventricular septal defect, and you will observe cyanosis on physical examination. So that is all about the clinical features of Fallot's tetralogy. And how is it diagnosed? Well, the principal diagnostic test is an echo, which will show all the 4 types of defects and will confirm tetralogy of Fallot's. On a chest x-ray, a boot-shaped heart is observed in advanced tetralogy of Fallot's. Boot-shaped heart is observed. On an EKG, there is right ventricular hypertrophy. EKG will show right ventricular hypertrophy. How is it treated? Well, it is treated by surgical correction, and surgical correction is done preferably before the age of 5. And if the defect is large, if there is in severe cases, it might be required early in the course of the disease and early in the children. Cyanotic spells can be improved by squatting, giving the patient oxygen, giving the patient oxygen supplementation. Beta blockers can be used. Beta blockers to decrease the adrenergic stimulation of the infundibulum of the pulmonary artery, to decrease the narrowing of that. You can use beta blockers as well, and knee chest position. Sedation can also be used to decrease the cyanotic spells. So that is all about tetralogy of Fallot. The next congenital abnormality of the heart that I'm going to be talking about is pulmonary atresia. In pulmonary atresia, as the name suggests, what happens is that the pulmonary valves are atretic. And when the pulmonary valves are atretic, the blood from the right ventricle cannot flow into the pulmonary arteries because the pulmonary valves are atretic. So what happens is that the blood regurgitates from the right ventricle into the right atrium. And from the right atrium, there must be a shunt present. And that shunt is either a foramen ovale usually. Foramen ovale or an atrial septal defect is present, which shunts the blood from the right atrium into the left atrium. And these patients also have a patent ductus arteriosus. Patent ductus arteriosus is required in these patients for pulmonary blood flow to occur. Otherwise, there will be no pulmonary blood flow in these patients. So what happens is that the blood cannot flow into the pulmonary artery. It is regurgitated back into the right atrium, and from the right atrium through the foramen ovale it enters the left atrium. From the left atrium it enters the left ventricle. From the left ventricle it enters the aorta, and from the aorta some blood goes into the pulmonary artery through the patent ductus arteriosus. So what are the clinical features? The clinical features are that these patients will present to you with cyanosis after 2 to 3 days of birth. After 2 to 3 days of birth. What is the reason why we present to you with cyanosis after 2 to 3 days of birth? After birth, the reason is that it is after 2 to 3 days after the birth of the child that the ductus arteriosus closes, and it is only after the ductus arteriosus, closure of the ductus arteriosus, that these patients will present to you with cyanosis. In addition to that, when you examine these patients, when you auscultate the heart, there will be a single heart sound, and there will be no murmur. There will be no murmur present. So cyanosis after 2 to 3 days of birth, single heart sound, and there is no murmur. How is it diagnosed? Well, it is diagnosed by an echo. Also, when you perform an EKG, you will find left ventricular hypertrophy on an EKG. So, how do you treat these patients? The treatment is surgical correction, but an important point for you to remember is that you have to keep ductus open. Have to keep the ductus open for some pulmonary blood flow to occur, and to do that, you give these patients infusions of prostaglandin E1 to keep the ductus arteriosus open. So that is all about pulmonary atresia. The next congenital anomaly of the heart that I'm going to be talking about is tricuspid atresia. Tricuspid atresia. In tricuspid atresia, what happens is that the tricuspid valves are atretic, that is, the valves which are present between the right atrium and the right ventricle are atretic. So then what happens is that the blood cannot flow from right atrium into the right ventricle, and there is an atrial septal defect or a foramen ovale that is present, which shunts the blood again into the left ventricle. And these patients either have an associated ventricular septal defect, they will have an associated ventricular septal defect, and also there might also be a ductus arteriosus. These patients have an advantage over the patients of pulmonary atresia is that the pulmonary valves are not atretic. That is, if the blood reaches the right ventricle via the ventricular septal defect, the sufficient pulmonary blood flow can occur in these patients. So, how do these patients present to you? These patients of tricuspid atresia present to you with cyanosis at birth. There is cyanosis at birth. Also on examination, there is a single heart sound, single heart sound and a pan-systolic murmur is heard along the left parasternal border. So cyanosis is present at birth, a single heart sound, and a pan-systolic murmur. How do you diagnose it? Well, the diagnosis is made by an echo, and also if you perform an EKG, an EKG will show left axis deviation. EKG will show left axis deviation and left ventricular hypertrophy. What is the treatment? The treatment is surgical correction. So that is all about tricuspid atresia. Next congenital cardiac abnormality that I'm going to be discussing is total anomalous pulmonary venous return. As the name suggests, in total anomalous pulmonary venous return, what happens is that instead of the blood going from the lungs into the left atrium, the veins, the pulmonary veins drain into the systemic circulation, and from the systemic circulation they enter into the left atrium, and then this mix from the systemic circulation the blood enters into the right atrium, and then this mixed blood enters into the left atrium, and there is also a high risk of obstruction of these veins. So how do these patients present to you clinically? These patients present to you clinically with cyanosis, and this is a cyanotic heart disease. So what are the laboratory findings in total anomalous pulmonary venous return? The chest x-ray in these patients will show a snowman configuration or a figure 8 configuration of the heart, and this is definitively diagnosed, can be definitively diagnosed by an echo, and these patients will require surgical correction as their treatment. If the pulmonary veins in the total anomalous pulmonary venous return are not obstructed, then these patients might not present to you with cyanosis. They will be asymptomatic. They will present to you with cyanosis later in the course of the disease. But if there is obstruction of these anomalous pulmonary veins which are connecting to the systemic veins, then they can present to you with cyanosis early in the course of the disease. So after this, I'm going to be talking about Truncus Arteriosus. Truncus Arteriosus is a congenital cardiac abnormality in which there is the pulmonary artery and the aorta are not divided into two. They exist in the form of a single blood vessel arising from the right and left ventricle. So they are not divided. And in addition to that, they have a ventricular septal defect which is always present with Truncus Arteriosus. So Truncus Arteriosus is pulmonary artery and the aorta present together and rising from the right and left ventricle, associated with ventricular septal defect which is always present with Truncus Arteriosus. In patients of Truncus Arteriosus, cyanosis is usually not present at birth because of the somewhat high resistance of the pulmonary vasculature at birth, which causes a normal pulmonary blood flow. As the resistance of the blood vessels of the pulmonary circulation decreases, the blood flow through the pulmonary circulation increases. Eisenmenger's phenomena, Eisenmenger syndrome develop in these patients, and it is then that these patients will present to you with cyanosis. In addition to cyanosis, an ejection systolic murmur can be examined, can be observed in these patients on examination, which is often associated with a thrill. Ejection systolic murmur associated with a thrill. It can be confirmed by an echo, and it is treated by surgical correction as soon as possible in these patients. So that is all about Truncus Arteriosus, and the last congenital abnormality of the heart that I'm going to be talking about is transposition of the great arteries. Transposition of the great arteries, or transposition of the great vessels. What happens in transposition of the great arteries is that the pulmonary artery, rather than arising from the right side or right ventricle, arises from the left ventricle, and the aorta, rather than arising from the left ventricle, arises from the right ventricle. So there is the distribution of these arteries is changed. They are flopped over. So that is what occurs in transposition of great arteries, and it is more common in infants who are born to diabetic mothers. It is more common in infants of diabetic mothers, and it is the most common cause of cyanosis within 24 hours. So if an infant presents to you with cyanosis within 24 hours, this is the most common cause of cyanosis within 24 hours, and it can rapidly lead to heart failure in infancy, and therefore it will require immediate surgical correction. Along with that, along with heart failure, features of heart failure, you can find a single second heart sound in these patients as well. A single second heart sound is also present in these patients, and a murmur may or may not be present in these patients. How is it diagnosed? It is diagnosed by an echo, is confirmed by an echo, which will show the aorta arising from the right side of the heart and the pulmonary artery arising from the left side of the heart. Also, when you do a chest radiograph, the characteristic chest X-ray finding in patients of transposition of the great arteries is an egg on string appearance. Egg on string appearance. Egg on string appearance on the chest radiograph. In addition to that, when you do an ABG, arterial blood gases level, the arterial blood gases levels is low, and these patients, this low levels of oxygen in the blood cannot be improved by supplementing the patient with oxygen. An important point to remember in the treatment of transposition of great arteries is that prostaglandin E1 infusions, PGE1 infusions, are required to keep the ductus arteriosus patent in these patients until surgical correction is done. Keep the patent ductus arteriosus patent. Keep the ductus arteriosus patent by giving them prostaglandin E1 infusion until surgical correction is done. So that is all about transposition of great arteries, and that is all about congenital abnormalities of the heart that you're required to know. Now I'm going to be talking about myocarditis. Myocarditis. As the name suggests, myocarditis is inflammation of the myocardium. And this inflammation of the myocardium most commonly is caused by viruses. And the most common viruses that cause myocarditis are the Coxsackie virus, and the second one is the adenovirus. So Coxsackie and adenoviruses are the most common viral etiologies for myocarditis. How do these patients present to you clinically? Well, the clinical features of myocarditis can vary from mild or asymptomatic individuals who are asymptomatic, individuals who present to you with mild symptoms who recover spontaneously, and individuals who present to you with severe myocarditis, who present to you with all the features of heart failure, such as dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hepatomegaly, peripheral edema. They present to you with features of right and left-sided heart failure. So features of myocarditis vary depending upon the luck of the patient. If the patient is unlucky, the patient will present to you with features of severe heart failure. What are the diagnostic tests that can be performed in these patients? Well, if you perform an echo, the echo will show globally decreased function of the heart. There is decreased left ventricular function, there is decreased right ventricular function, the chambers of the heart are dilated. The same findings can be seen on a chest x-ray, which will show dilated chambers of the heart. Cardiomegaly will be observed in these patients. And viral titers can be performed in these patients, which if positive can give you an important diagnostic clue in these patients. But the definitive and the gold standard test for the confirmation of myocarditis is endomyocardial biopsy. Endomyocardial biopsy is the gold standard test, but it is usually not performed, and myocarditis is essentially usually clinically diagnosed. What is the treatment of myocarditis? Well, the treatment of myocarditis is generally supportive treatment. If the patient presents to you with signs and symptoms of heart failure, you just manage those symptoms symptoms of the patient and hope that the signs and symptoms will resolve. If the signs and symptoms do not resolve and patient goes into intractable heart failure, these patients require a heart transplant, and these poor patients cannot be cured with any medications. All that you can offer these patients is supportive treatment and eventually a heart transplant. Spontaneous revolution can occur in these patients, so that is a ray of hope in these patients. So after myocarditis, I'm going to be talking about endocardial fibroelastosis. Endocardial fibroelastosis. As the name suggests, in endocardial fibroelastosis, the endocardium of the heart becomes thick and fibroelastic. Endocardial fibroelastosis is of two types, primary and secondary. In primary type, there is no associated abnormality. That is, this endocardial fibroelastosis is of idiopathic pathology. There is no associated pathology which is leading to this cause, and these patients of primary endocardial fibroelastosis have a dilated cardiomyopathy, or dilated chambers of the heart are present. In secondary type of endocardial fibroelastosis, what happens is that there is ventricular outflow obstruction, and due to that outflow obstruction, the endocardium of the heart undergoes thickening. There is fibroelastosis, and in this case, there will be constriction of the ventricular cavity rather than the dilatation of the ventricular cavity that occurs in the primary type. How is it diagnosed? Well, if you do a chest x-ray, you will find enlarged cardiac chambers, and an EKG will show left ventricular hypertrophy, ECG will show left ventricular hypertrophy and left ventricular strain pattern, and it is an echo can be done. An echo will show poorly functioning ventricle. So how it is treated? How is it treated? It is treated. The only thing that you can offer these patients is heart transplant, and there is no medical treatment for this endocardial fibroelastosis. So that is all about this condition. Now I'm going to be talking about an important topic, which is rheumatic fever. Rheumatic fever. Rheumatic fever is a disease which is caused by infection by group A beta hemolytic streptococci. Group A beta hemolytic streptococci. So this infection occurs 2 to 3 weeks after a sore throat, usually after 2 to 3 weeks after a sore throat that the patient has developed due to this organism, group A beta hemolytic streptococci. So how does a heart disease, or how does rheumatic fever develop from infection of just the throat? What happens is that when the patient is infected by group A beta hemolytic streptococci, in the cell wall of this bacteria there is a protein which is called as M protein. To this M protein, antibodies are formed against this M protein, and in some genetically susceptible individuals, these antibodies cross-react against the heart. They cross-react against the heart, they might cross-react with the joints and other parts of the body, leading to rheumatic fever. It usually occurs in 5 to 15 years of age. So the age group is between 5 to 15 years of age. And what is the diagnostic criteria for rheumatic fever? Well, Mr. Jones has devised a criteria which is called as Jones criteria for the diagnosis of rheumatic fever. Since it is clinically diagnosed, therefore he has proposed a clinical criteria for the diagnosis of rheumatic fever, which includes 5 major criteria and 4 or 5 minor criteria. The major criteria include arthritis, carditis, erythema marginatum, chorea, and subcutaneous nodules. These are the 5 major criteria for the diagnosis of rheumatic fever. Arthritis occurs in 75% of the cases of rheumatic fever. In 75% of the cases of rheumatic fever, they have arthritis, not arthralgia, arthritis. The difference between arthritis and arthralgia is that in arthritis there is a red, swollen, tender joint, whereas arthralgia is only active pain in the joint. So remember, these patients will have arthritis, and the type of arthritis, the characteristic type of arthritis that these patients will experience is a symmetrical migratory polyarthritis. The arthritis is symmetrical, that is both sides of the body will be affected equally, and it is migratory, that is, it affects one joint. For example, it will affect ankle joint today, and the next day it will affect the knee joint, and the next day it might affect vertebral joint. So it is a migratory type. It skips from one joint to other, involves multiple joints. So these are the characteristics of arthritis. Carditis in rheumatic fever is a pancarditis. What I mean by pancarditis is that in rheumatic fever, pericardium, myocardium, endocardium, all 3 layers of the heart are affected. If the endocardium isn't affected, these patients can present to you with valvular heart disease, they can present with valvular heart disease, and they can present with vegetations on the heart valves. They can present with vegetation on the heart valves. When there is myocarditis, these patients can present to you with features of heart failure such as dyspnea and so forth. When there is pericarditis, these patients can present to you clinically with a pericardial friction rub, and they can also present to you with a pericardial effusion. Erythema marginatum is a red macule, appears in the form of a red macule with central clearing as it goes on. So a red macule with central clearing, there is clearing of that macule from the center, but on the periphery it remains red. So that is how erythema marginatum appears. Erythema on the margins. Subcutaneous nodules can also be present, which are an uncommon feature of rheumatic fever, can be present in some individuals. Subcutaneous nodules, basically the basic pathology in subcutaneous nodules is a vasculitis. So in subcutaneous nodules, there is a central area of fibrinoid necrosis, which is surrounded by macrophages, and it occurs at various parts of the body. Subcutaneous nodule, various parts of the body which can be felt, such as the elbow and so forth. Chorea is a very abnormal feature of rheumatic fever. What I mean by abnormal is that patients might have developed rheumatic fever, say 6 months back, might not have suffered from rheumatic fever at all, might not have suffered from arthritis, might not have any feature of rheumatic fever, and they present to you with chorea only. So chorea occurs greater than 6 months, usually greater than 6 months after an attack of rheumatic fever. After 6 months of rheumatic fever, and they all of a sudden present to you chorea, and you might not be able to elucidate any cause of chorea in that case. So if there is, if a patient presents to you with chorea in which you are unable to find a cause, always suspect rheumatic fever as the cause of chorea, and this type of chorea in rheumatic fever is called as Sydenham's chorea. So these are the major criteria for the diagnosis of rheumatic fever. There are certain minor criteria as well, which include fever, raised acute phase reactants, increased ESR or increased C-reactive proteins, which are acute phase reactants. Arthralgia is another feature which is included in the minor criteria. Along with that, a prolonged PR interval, increased PR on EKG is another minor criteria. And Along with these minor and major criteria, another criteria that is added to both these is that along with these two criteria, evidence of a streptococcal infection must also be present. Evidence in the form of anti-streptolysin O antibody, evidence in the form of anti-DNase A antibodies, and so forth must also be present in this case. So, to diagnose rheumatic fever, either two major or one minor criteria, or one major or two minor criteria are required for the diagnosis of rheumatic fever. But arthritis, along with arthralgia, cannot be one major and one minor criteria. If the person has arthritis, then you cannot have arthralgia as one of the minor criteria. And along with these, this diagnostic criteria, evidence of cold infection is also required. So how do you treat a case of rheumatic fever? Well, rheumatic fever is treated by treatment of streptococcal infection, treatment of the streptococcal infection with penicillin. If there is a streptococcal infection, just treat that with penicillin. And to prevent the recurrence of rheumatic fever, you give these patients penicillin prophylaxis every month. And usually they are given intramuscular injections of penicillin every month instead of the oral penicillins, because that then there will be an issue of compliance of the drug. So you just give one intramuscular injection of penicillin, long-acting penicillin, which will do the job for 1 month. For arthritis, you give NSAIDs, and you give steroids if there is severe carditis. If the patient presents to you with severe carditis, you give NSAID. And if the patient presents to you with heart failure, you treat the heart failure. Patients of rheumatic failure can develop long-term complications such as mitral stenosis, long-term cardiac complications such as mitral stenosis. The mitral valve is most commonly affected in all the valves. The most common valve affected is mitral valve, and then comes the aortic valves, and other valves come later. The most common valve is mitral valve, and these patients can present to you with chronic rheumatic heart disease, with mitral valve stenosis, mitral valve regurg, aortic stenosis. They can present to you with tricuspid stenosis. They can present to you with any valvular involvement, but the most common is mitral valve. So that is all about rheumatic fever and its treatment. Now I'm going to be talking about hypertension in the pediatric section. If a child presents to you, if a young child presents to you, say a 5-year-old child presents to you with hypertension, raised blood pressure, 5-year-old child with blood pressure, how is that possible? Well, it is possible. The most common cause of blood pressure, raised blood pressure or hypertension in childhood is renal disease. Renal disease. Remember that hypertension is of two types: essential hypertension or primary hypertension, or secondary hypertension, which is secondary to multiple causes. The hypertension in children is usually secondary to renal disease. Other causes of hypertension in childhood, in young childhood, include coarctation of the aorta, coarctation, which is an important cause, which must be ruled out. So these are the top two causes of hypertension in children that you have to rule out. So what do you do to rule out these cases? You examine the child. These patients of renal disease can have two types of renal disease leading to hypertension. They can have renal artery stenosis, and renal artery stenosis in young children can be due to fibromuscular dysplasia. Fibromuscular dysplasia, and sometimes patients who have history of umbilical artery catheterization can have renal artery stenosis or blockage of the renal arteries can lead to hypertension. In addition to that, if you investigate the patient of renal artery, you do a urinalysis, you try to find out, you take the history from the patient. These patients will also give you 25 to 50% of these patients will give you a history of urinary tract infections. 25 to 50% of these cases will have a history of urinary tract infection. infection due to urinary outflow obstruction, which has led to renal disease, which has eventually led to hypertension. So how do you investigate these patients? You investigate all the renal parameters such as blood urea nitrogen, creatinine, renin levels, renal ultrasound. So you do all these things to rule out if there is any renal involvement or not. And to rule out coarctation, clinically you measure the blood pressure of the upper extremities and the lower extremities. You check for radiofemoral delay, radioradial delays, and that is how you will be able to differentiate coarctation from other causes of hypertension. And the treatment of hypertension in childhood is essentially similar to that of adulthood, in that renal artery, in the unilateral renal artery stenosis, the drug of choice will be ACE inhibitors, and beta blockers, calcium channel blockers, and other drugs for hypertension can also be used. But that is all about the pediatric section of cardiology.